adapted to the mountains. And the easiest way is, to be honest, to have much more information than what I even know, is just go to the website airway.ch, and you will find training, and you will see the courses we offer. So it's, for you of interest, it's either the Mountain Emergency Medicine course, which is ICAR approved, or the AHAMS. It's more like helicopter technical related rescue course. So Leonie, she's in charge of that. So if you have any questions about signing up, more information for the courses, she will be at the bar tonight together with Stutzi. He's the Claudio Stutzi. Sorry, we call him Stutzi. Claudio, he's the head of training center. So they'll be there asking questions, sign up for the courses, and we'll see you again. Then the last thing, tomorrow morning, 6 o'clock, there's a running group. Who's going to do it? Yeah? 2, 3? That's it? Come on. You guys know how many calories that fondue has tomorrow night? There we go. So we'll have 2 running groups tomorrow morning, okay? So one will be with Rebecca, and one will be with me. 6 o'clock in front of Hotel Alex. We wait until 6:01 and then we take off. We'll be back here at 7. Don't worry about that. No, it's not going to be anything bad, but it will be lovely. You will enjoy.
Thank you. And now, first of all, thank you. You came here on such a beautiful day and you went inside to be together with us. That's an honor, my respect. We will have until 10 o'clock as a multi roads airway workshop. There will be talk, there will be hands-on, there will be discussion. And I would like a pointer. First, I'll introduce, let my co-arranger, Michael Friis Tvede, very briefly introduce himself.
Hello, friends. Working? It's working. Yes, name is Michael Tvede. At least that's how you pronounce it internationally, I think. In Danish, it's Tvede, but you cannot say that, so we'll stick to Tvede. I'm a consultant anesthesiologist working in Copenhagen together with Michael, working in critical care and pre-hospital from car and helicopter as well. More about that later. Thank you very much.
My name is Michael Sels Christensen, and I'm a consultant at the same place, Rigshospitalet in Copenhagen. That's a referral hospital for everything. We don't say no to any offer of an exciting patient, so try us there. From the beginning of my career, I have realized how ugly situation it is to get a person whose airway we couldn't manage, especially if we have a patient with whom we've spoken and then put him to sleep and then we're not able to manage the airway. That's an ugly situation. So actually I've used my professional life trying to avoid that personally at a hospital level and at a global level. We work on that. One of the things we do is that we have a yearly course in airway management in Copenhagen, airwaymanagement.dk, and that works as a working laboratory. Every year we scrutinize the world for new knowledge in this field, new speakers, new devices. We run investigations along the year, and it culminates there. And then, since 4 years, 1 month later, we distill this. This is a 2-day course. We distill it into a 5-hour thing. Here, we take the best, most dynamic parts of it and offer it to those of you who take the long ride to Zermatt. With us today, we've got Loes Brustens from Nijmegen. It's unpronounceable as well, from Nijmegen in Holland. And she has a long time interest in airway management, especially in front of neck airway access in teaching, research, and scrutinizing what really goes wrong when it goes wrong, and it will help us with that. We've got Camilla Strøm, who's even younger colleague, airway management aficionado, did studies on how to combine airway management techniques, and she'll show one of these beautiful techniques later on. And look at this. We got nice colleagues helping in the afternoon with the hands-on part of the workshop, from Holland, from Denmark, here from Switzerland, from Geneva, and you'll meet them later on. So the frame is that we will have talks, the four of us first, and then we'll get the question and discussions after these talks, because maybe you already got the answer during one of the other talks. And then at the workshop tonight, all details can be discussed and challenged as well. We won't leave without learning from this experience either. And then not only do we have the course, we also last year we got all the knowledge together in a something as old-fashioned as a textbook from Cambridge University Press. We asked more than 60 colleagues from around the world, known airway managers, to contribute with state-of-the-art in airway management. And this can be yours. In the end of the talks here, we'll have a quiz that you can go to on your smartphone, and then 2 of you will be the lucky owners of this book later in the evening. And almost all the questions can be answered by listening to the talks. There's also a bit about Zermatt in general. Before we move on, we have to go directly to this topic, Danes and skiing, because there's so many Norwegians here among us, and they always tease us. They say, "Oh, Danes can't ski. They come from a flat country. Oh, they are on our slopes, and it's annoying." And we are actually annoyed by keeping hearing about that. So now we try to make revenge. This is in the middle of Copenhagen, near to the harbor. We build a mountain when we don't have it. It's on the top of the world's most modern combustion plant, so all the waste from Copenhagen is burned and turned into electricity, and on top of that you can go skiing. So come to Copenhagen for that. So we try to get better. This is the view from up there, and as all of the surroundings are flat, it's actually a very good view. This is the pull lift. This is to the top, and this is the after-ski bar where you can face all the western part of Sealand, a great part of Denmark. It looks like this, setting sun, and my son on snowboard there. We had a fun day. Okay, but not if that will not persuade the Norwegians to say, okay, Danes can ski, then Denmark is not only the main part, it's also the world's largest island. We got an ice cube 2,000 kilometers along there, the inland ice. And there we got this means of transportation, and we got snow. I tell you, we got mountains. 3.6 kilometers is actually the highest mountain in the Kingdom of Denmark. We had the occasion to go there, give anesthesia with very simple means. We'll talk about airway management with simple means as well. Going by dog sleigh, and being at Karnak, north of Thule, I looked at this mountain. Say, this is an iceberg stuck in the ice, and said, "Can you ski that?" And you can. But under a small, tiny bit of snow, it's like an ice cube, so it is fairly difficult. Okay, airway management. First, all the Norwegians keep silent. That's good. that's rare, though. What has happened since Big Sick 2020? We were here 2 years ago, and what has happened? No secret. When we were here, we had just heard about something from China, a little bit coming to Italy. We actually faced that in a lecture, trying to see how can we prepare to not get contaminated as practitioners ourselves. And from talking to our colleagues in Italy there, when we came home from Big Sick, we understood that they actually got sick from this severely. In the beginning, it was a serious disease, and it may be again. So we actually worked on trying to diminish the load of sputum in the post-operative recovery area in a simple means that you can use everywhere. Please start the video. So we published this in BJA, a very simple means. If you go, it is a video. I have been rehearsing it. Can't you go to the mode where you have Oh, please turn up the sound. Okay, so this patient had anesthesia. He's intubated. Please turn up the sound. And we suction the patient before he's going to get extubated. And then
the nasal
oxygen
cannula
we place
before
a nasal
extubation.
oxygen, binasal
Leave
oxygen,
the
so that
filter
it's
under
ready.
the tube.
And then before
Place
extubation,
the
you place
surgical
the
mask
face
on-
mask covering the whole thing. And then, did you stop the video? Then you extubate while he's wearing the face mask, and he can go on to the recovery room like that. Very cheap and very efficient.
The patient.
Okay. So we'll skip this, but please make the. It will be kind of you if you can make the other videos run and also with sound sufficiently loud. So. Okay, is it possible to turn on the sound further?
Extubate.
Okay, it all worked when we tried it, but that's how it is. Okay, and then you extubate by pulling the tube under the draping. Okay, I would like to go on to the next. Please, how do I change to the next slide? Okay, so it would be very kind of you, because we've got many videos. We prepared a lot of videos for you, so it would be kind if you could make them run. What is airway management? It's bloody amazing. It's managing this tiny part of anatomy from out here down to somewhere in the trachea, maybe to the mainstem broncho. This small area has to stay open all life. Otherwise, after we come out here, we get the umbilical cord cut. That's our nature's own heart-lung machine. And from that on, and the next 90 years, the airway has to stay open. Otherwise, we get brain damage or die. A few exceptions. This one will not change the slide for me. Okay, so I'll keep. There are some exceptions to this, of course. If you have your head cooled down very much, or you are on a heart-lung machine, then you have a few more minutes or a little longer time, of course. But the special thing is, this is our responsibility. Most of you are actually anesthesiologists. Thank you very much. I saw on the participants list, and this is our responsibility. We cannot just write a prescription or ask for a surgeon. So we are the ones who know when is this, can this be difficult, when do we need to proceed, when do we need to make an emergency procedure. So our responsibility. I'll refer to this old study, but it's still the best ever made in airway management, and it's still actual. They asked all hospitals in the national health system for, in a 1-year period about cases of death or brain damage or unplanned admission to ICU due to airway management. And there were these 19 deaths of brain damage related to general anesthesia, and 22 related to ICU treatment. And they analyzed these cases in depth, which was really amazing work. And in 3/4 of the cases, we could do better next time. And ICU and emergency care is highly overrepresented, so now it gets even more relevant for our group here. And this is only the tip of the iceberg. There's a lot underneath. This is a minimum figures. And the most important is that this is most often preventable, meaning that it actually pays off making an effort to train, to be good at this. And especially what happened here is that they failed to plan for the airway management, and in case that there was a plan, failed to follow the plan. So we'll discuss that and get good at that. There are 7 main routes for for oxygenation and CO2 removal in our patient, we can just do like we do now, breathe spontaneously. We can breathe spontaneously with added oxygen. We can put on a face mask. We can put the face mask into the mouth, covering larynx, then it's called a laryngeal mask. We can put it further down to the trachea, then it's called an endotracheal tube, or we can enter it via the front of the neck, then we got a tracheostomy or cricothyrotomy, or we can avoid it, we can put catheters into the circulation and have ECMO or heart-lung machine. So, but we need a plan, we can't just randomly choose any of these, so we must have a plan. And there's news for us. This past half year, we got 2 new airway management plans. To the left, we got the ASA, American Society of Anesthesiologists, guidelines, and to the right, we got the Canadian guidelines. All just came out a few months ago. And I read them carefully. We've also been discussing with these people and coming with input. In my opinion, the American guidelines, and I know we are some Americans here, I want your opinion later on, they are mostly written in order to keep the anesthesiologist out of prison or avoid that he should pay anything. Whereas the Canadian guidelines are meant for actually helping us making a plan to treat our patients. And I think that's the approach that we used in most of Europe. So if we look in a bit more detail, the Canadian guidelines, they consist of 2 pieces of paper. The rightmost is the predicted difficult airway. And there is a key recommendation that prior to airway management, a documented strategy should be formulated for every patient based on airway evaluation, meaning that we have to do something, at least ask the patient to open the mouth. That's a minimum. And I recommend these 2 papers. They're actually freely downloadable. There's so much good stuff in there that it actually is a whole textbook of airway management. They also made an algorithm, and we won't go through the details, but we'll look at the main principle. So it starts here. We have a patient that for some reason is predicted to be difficult to intubate. Then we should ask ourselves some questions, namely, do we urgently, is an awake intubation clearly indicated? That could be, for instance, if we can only open the mouth 1 centimeter, for instance, then it won't help trying to intubate in a normal way. If that's the case, then we should do it. We'll see later what to do. Then we should ask ourselves, will mask ventilation or supraglottic airway device be easy, doable? And if you say no, and we'll see what happens. If you say yes, then we should ask ourselves, and this is new, we should also are there physiological issues that may impact this airway management? And we need to pay attention to that as well, and especially if the patient has a lower apnea tolerance, for instance, because he's obese with reduced functional residual capacity, or has an increased oxygen consumption, maybe from high fever, or already a baseline hypoxemia, as many of our severely ill patients have, especially this first hour. And then a special indication, haemodynamic instability can itself be an indication for awake intubation. So if we say no to that, and we also think, is there something that indicates that front of neck airway access should be difficult? Because that's also an important part of our algorithm. We'll look at that. If we can say no to all this, then we move further down in this algorithm. And then the next question is contextual issues, and that's also new, meaning the setting that we are in, for instance, an adverse location. And that's many of the locations that we heard about this morning as well. They're really adverse, remote, difficult access to the patient, for instance. Don't we have any help or backup? Or are we inexperienced, the group we are right here? Do we have equipment or not? Is there such a bad communication, for instance, that we can't rely on any colleagues? Some of you will all of a sudden work in an area where you don't speak the language. If we can say no to all this, then all these questions, if you say no, then we can go on, for instance, put the patient to sleep and have a good chance of having successful airway management. If, on the other hand, we say yes to any of these questions, then we should at least consider this patient, will the patient be able to cooperate for an awake airway management, and is there time for that? And if that's the case, then we can do awake intubation or maybe awake tracheostomy or cricothyrotomy. If we say no to this, then we go to another Canadian specialty, namely the double setup in airway management. And components for that are, first of all, we identify and mark the cricothyroid membrane before any anesthesia. And if necessary, we use ultrasonography for that. We decide who in the group, in the team, will do the front of neck airway access in case we'll need it. We are sure that we have the right equipment and we have it ready. And we brief the team with what will be the trigger here for doing a front of neck airway access. So that's a double setup, meaning that if we do that, then we induce the anesthesia and manage it, and sometimes this will be successful. If not, then we are very, very ready for the front of neck airway access. There's another part of the airway algorithm from the Canadian colleagues. That's the unpredicted difficult airway. So all of a sudden we got a patient, we want to intubate him, but we can't. We had no chance. Maybe it was an accident. He's just lying there, and we don't want to go into detail. Of course, we try the mask ventilation, face mask, and so on. And if that's successful, then we have time, can do something else. If that's unsuccessful, then, as in all other airway algorithms, we go for a front of neck airway access. So that's the brief message in these combined Canadian guidelines. So now we got this fundament, we got data showing what goes wrong, and we got new, very well thought of guidelines. How can we improve success further? It's not enough to have these papers. We have to fill something in. We have to rehearse the basic things and get good of it. One thing we can do is we can practice combination techniques, because it's not either or, it's often both and that can largely increase success. All of these nice airway techniques, and they get coming more every year, can be combined to new success. And one of the fundamental combinations is a supraglottic airway combined with a flexible scope, and I want to invite Camilla to tell us about that. Please. So,
sure, I can do
yes.
whatever.
Yeah, she's a female. She can multitask. That would never have worked with me.
So is this working? It is. Thank you so much. So for the next 10 minutes, my battery is running low, it says. Can you... it's working? Not working?
We have a pointer that can change to the next
the mic,
slide.
this is not working, sorry. Yeah. So what I will tell you about in the next 10 minutes is how you can combine a technique for mostly doing this in resuscitation, afterwards resuscitation phase. So how to use a fiber optic bronchoscope intubation through a supraglottic airway device. And imagine you've been called into a room where this patient is lying with no airway at the moment you have been called. So your older colleague is usually used to always being able to intubate patients. Of course he could intubate this patient, but they could actually not get any oxygen, they could not ventilate the patient, you could not oxygenate the patient, you could not intubate the patient. At that moment in time, you're going through your difficult airway algorithm, and first, of course, you need to have awareness that this is the situation we are in, so what needs to be done? So your colleague didn't, at that point, give them muscle relaxants. You do that, doesn't help. Next phase, down your airway algorithm is to put in a supraglottic airway device, and thank God you succeeded. You can now oxygenate the patient. So you have time to think. Can I awaken the patient? should I proceed? In this situation, let's imagine that you have to proceed with the surgery. What to do then? So the NAT4 study that Michael told you about, it clearly showed that proceeding surgery after a case of failed intubation with a supraglottic airway device is associated with significant morbidity. So instead you can secure the airway. And it's not working. No, the changer. So, yeah. But do this in a non-blind technique. If you look into the literature, using blind techniques is only associated with maybe a 15% chance of actually succeeding, and you have the, on the other hand, risk of putting major airway trauma into the patient that you already had a lot of trouble dealing with. Most of you probably know the intubation laryngeal mask, where you have this still a blind technique with an introducer. Literature says you can increase your success rate maybe up to 75%. But if you use a fiber optic bronchoscope to put in the tube, you can actually increase your success rate from a 95 to 100% if you look into the literature. So which supraglottic airway device should you use? I would just say there's a ton on the market, and there has also been a dozen of studies that really might show small significant differences, but not clinically relevant differences. What's in it for you is to know what exactly the equipment you have at home, what is it, and which tube size can they actually accommodate. Because, for instance, the LMA Supreme, it has such a narrow stem that you cannot fit in the tube in the bronchoscope. You might go for an intubation catheter. Many of you, or some of you might have been working in the UK, you would know the Aintree catheter. I would just touch upon it in the end. You should also know that doing this procedure, you need to train it. Because if you just make into how many detailed steps you actually have to go through, you can count it up to 30 steps. And imagine you have just been in the situation where you could not ventilate the patient, oxygenate the patient at all. Thank you. So imagine what state of performance you will be in. Next. So I will show you how this can be done. And if you can start the video. So this is a patient where we anesthetize the patient. We put in a supraglottic airway device, and we verify the placement by positive waveform capnography. What I do now is at first I put in the ETT in the tube. I know exactly how far it should go to not get out of my supraglottic airway. I fixate it afterwards by just putting air into the cuff, and I put on my connection piece, and then I reconnect my ventilator, and to see that again I have a positive waveform capnography. So this is a major advantage of also doing this procedure, is that you can oxygenate and ventilate the patient throughout the procedure. I have to have a connection piece where the port fits in the bronchoscope, and I suggest that you make small incisions in the port to actually make insertion go easier. So we do that, just small incisions. I still ventilate the patient, and of course there's a little bit of air spill, but it's all right. I now put in my bronchoscope and advance it through the whole package. And what you can see here is that the supraglottic airway device has been perfectly fitted, because when I come out, I have a great view of my vocal cords. I know exactly where to go. I advance my bronchoscope, and I want to go all the way down to the carina, because at that point I actually remove my fingers from the bronchoscope, because now I want to advance the tube. What I do now is that once again I take off the cuff. I can now advance it. I make sure that the bronchoscope is not added further down. Yes, it's down. I inflate the cuff and I retract and make sure that I'm in the right position. Yes. So now we have the tube inside the patient. I reconnect and I see again positive waveform capnography. We are in the right place. Again, we have time to think at this point. So, are we in a position where it's okay, fairly safe to let others in the patient, or do we actually need to remove it? Can you take the next slide? Yeah, and one more. So I'll show you 3 ways of how to remove this. So you can, if you play it, you can use another endotracheal tube if you don't have anything else. Just be careful that the cuff can actually be stuck, and I'll show you how it looks in a patient in just a second. That's one. So you can also take actually the cuff and put it in here when you advance it, because you actually can see that it's it can be easily to put it through the supraclassic airway. The last one, which is my favorite, is using McGill forceps, because I feel that I have a much more stable hand or grip. So what we do here is that I just actually stabilize the tube by the McGill forceps, and then I carefully draw the supraclassic airway back. You have to be careful that you don't put it in too far deep. I mean, you can retract it again, but it's just, and it's not that straightforward, and I will show you that in the next video, where we did this in a patient where I have a helper. She's a very experienced anesthetist nurse. I think if you take the next one. Yes. The next one. It's coming. Yeah, so she's a very skilled and trained anesthetist nurse, but you need to really be sure that you know what your helper is doing, and they need to know what they are going to do. So what I do here is we now disconnect, and to remove it, I tried just using the other tube, and you can see she needs to get her hands down the patient's throat to actually stabilize the tube to not extubate the patient. And you can see it's just not straightforward. And what we encountered here is that the cuff actually gets stuck. And you see, and it's just an example that this is not straightforward. You need to go home and practice, and you need to be in the situation where you're going to do this. You need to be very careful to instruct your colleagues to do the correct things. What we do now is we reconnect again, of course, and we ensure again positive waveform capnography, and afterwards I take my bronchoscope and I verify the placement, and also to know like how far down, of course, in the trachea have I gone. So I put in the bronchoscope again, and you go straight down to the carina, and at that point, when you are at the carina, you put your fingers before retracting it to the tube. You can actually measure, so how far down have I placed my endotracheal tube. Great, I can fixate it and I can go forward. Yes, please, next slide. Can you take the next slide? So again, another, a little bit, yeah. Some of you might know the entry intubation catheter. The thing is, it's like a tube exchanger that you put on your bronchoscope. And next slide. And then again, you have put in the supraclassic airway, and you can now take the bronchoscope with the entry catheter on it and introduce it through, again, a connection piece. And next slide. And what you do now is you afterwards can remove the supraclotic airway. Next slide. And you can railroad your tube on the exchange catheter. I would recommend, like they have shown here, that you use your laryngoscope to actually guide you. And I think also the thing about this procedure is that you don't oxygenate the patient in quite a long period of time compared to the other method. So that is why I prefer the other one. And I think this is also a somewhat blind procedure when you go to the next step. And next one, please. Yeah, and you place your tube, and you do again, you verify your placement by positive waveform capnography. So last slide. What I really want you to take home from this is to come to the workshop and practice this. You should know that it has a high success rate, of course, if the supraclotic airway has been correctly placed. You can maintain oxygenation and ventilation during the procedure, which is a major advantage. You should also know that removing the supraclotic airway after ET placement is not without risk, and you really have to train. I think this is the most stressful procedure or step of the procedure. And then please go home and know your equipment. So which tube sizes do you actually fit in this, and do we actually have the connection pieces we need to make this procedure? And please train and maintain your level of expertise. We're just finalizing a study as we speak, where we have actually a videotape. We did a randomized trial using 2 different supraclotic airway devices to see how good they perform. But on top of that, we actually look at physician performance. So each physician, there were 25 physicians doing 4 intubation each, where we're looking at how do they actually perform. I can't reveal the results now, but I can reveal that you have to go and train. Thank you.
This is really a core skill, and you get surprised if you read about it, that we actually need to practice. And just having done it twice will make it much easier when you need it. Okay, there are more combinations. This is a combination of G-tip ventilation and flexible endoscopy. This lady, for instance, she can only open her mouth 30 millimeters, and there's no access via the nose, and she needs anesthesia for this time for surgery. How can we do this changer? Doesn't work. No. Could you please next slide? Okay. G-tip ventilation, that's a technique that means tube tip in pharynx. We open the mouth, introduce the standard endotracheal tube, 10 centimeters, 10-12 centimeters. Next slide, please. And then we inflate the cuff with 20 mils of air. Next slide. Then we close the nose and mouth. Next, please. And then we can ventilate. This is a kind of poor man's laryngeal mask airway. It has been life-saving in certain situations. Please start the video in the lower corner. No, not this one. No, the big one. Yes. So it's this easy. This is a nurse anesthetist who only had it demonstrated once. Introduce the tube. And then fill the cuff with air. And then close the nose and mouth and ventilate. So this is an old technique. We still revert to it when we can't ventilate. And we know it's been life-saving. But this lady, how do we manage her airway? We combine, again, like this before, this time we combine the T-tip with the flexible endoscopy. Please start the video. So, very restricted mouth opening. She gets some local anesthesia. We prefer transtracheal anesthesia. She can only open her mouth just enough to accommodate the tube. She's got some local anesthesia. That's all. And she's breathing spontaneously, of course. And this is my resident. First order. Good advice from the other resident. Turn on the camera, yes. So we have a nice collaboration. And then we combine, we have the T-tip, the tube tip pharynx, we combine the flexible endoscopy because we don't have space, not even for an oropharyngeal airway. Then and then if we don't see anything, then we can inflate the cuff. That will put the tissue apart so that there will be space, and combine that with a slight retraction of the tube. And then we expect to see part of the larynx, which comes into view. Now, please ask the patient to take a deep breath, and this is what we already know, how to proceed from there. Introduce the flexible scope as we are used to into the trachea. We can look for the IV cannula here. We makes the patient cough so that she clears the lens. And there you see the IV cassettes that we use for local anesthesia, transcricoid membrane, and then introduce the scope until we can see the carina. And then empty the cuff. And introduce the tube. Sådan. Okay. And in this way, the combination gives us successful intubation. We may even avoid an unnecessary tracheostomy. Another example, we'll go on to another example of combination techniques. Again, this time the flexible scope, and then infrared technique. If there's so much pathology, we can't find our way. There may be a tumor, there may be infection. If we look into the mouth, into the pharynx, and it's all tissue or maybe even blood, and we can't find the little hole in the big hole, I mean, we can't find the hole to the airway. And in pathology, it could be here or here. Wouldn't it be nice if we could make flashing light come up from the trachea so that we combine and go towards that? And that has now become possible. And again, you can try this in the workshop. She's scheduled for awake intubation. We put the infrared flashing light on the cricothyroid membrane, and then we go with the flexible scope and we look for the light. And we've got this patient. Please start this video. You can see from the outside infrared lights, and then when we get in, you can see she has a difficult anatomy. She has a tumor in there, not easy to see where her windpipe is. It would be nice to get some guidance here. Oh, where may it be? Oh, you saw a tiny bit of, could it be over here? No, where's the flashing light? Look for the flashing light. Yes, there it is. Infrared light sent to the anterior neck, seen by the camera of the endoscope. Look forward to try this in the workshop. And there are many more combinations, and we describe those in the book. Okay, back to our quest to improve success further. Now we looked at combination techniques. Then what about out of operating room settings? Michael, please. Tell us about that, because there we definitely have contextual issues. Many things are different, and also often physiological issues. Please.
Yes.
Yes. And
Working? Yes. A few minutes about what's different doing trauma and pre-hospital airway management. Always a picture of a helicopter. My name. Let's begin with a case. 74-year-old male witnessed cardiac arrest, bystander or immediate responder CPR, wife. Ambulance arrive after a few minutes. Shockable rhythm, one shock, going to asystole, and then return of spontaneous circulation after 10 minutes. Assessment, A is free, B no respiration, an LMA, second generation, an ambu auric gain is inserted. End-tidal CO2 is 8.4. Bluish skin upper thorax and the neck. Radial pulse is 80. ECG shows STEMI. Patient is unresponsive. Normal pupils. He is accepted for primary PCI after teleconferences by the ambulance, the EMT, and it's assessed that flight time to PCI center is 37 minutes, and HEMS is requested. So let's set this aside for a few minutes and talk about what is different. We'll get back to the case in a short while. When doing trauma and pre-hospital airway management, what's normal is the case is that it's much earlier after onset of the illness or injury than you normally experience in hospital. You would often have none or at least limited information about past medical history. Backup is extremely limited or not existing, and your toolbox, even though many modern pre-hospital services are pretty well equipped, the toolbox is still limited. Positioning of yourself to the patient may be difficult to get 360 degrees access to the patient, which is your ideal situation. Lighting may be cumbersome, and the environment, the total environment, rain, snow, temperature, could be a problem as well. Also, you will feel some pressure regarding the time you have to spend on the scene. Unseen time is an issue when you do pre-hospital work. There is this old discussion, should I scoop and run or stay and play? I don't like either of those descriptions. I tend to use this expression instead. Let's treat, load, treat, go. But what about airway management? Is it important which strategy you choose? Well, probably it is, but it's hard to get hard evidence on which solution is the right one. Last year in pre-hospital emergency care, a large systematic review was made, 630,000 patients, 99 studies. And they only were able to conclude that actually it's not easy or at all possible to find support for choosing one strategy over the other, over the others. And we have to realize that sometimes the best airway management is no airway management. But sometimes, however, you have to do endotracheal intubation as the ultimate way of managing the airway. And when you do so, you have to do it safely and quickly. And we are quite good at that. In 3 different studies from 16, 17 and 18, first pass success rate with the video laryngoscope were found to be between 92 and 98%. To do so, you have to practice and to have some supportive measures. For instance, a kit dump, which is the same every time, so that you get better and better each time you do it. This is our kit dump in the Danish helicopter service. The only problem is that we now use video laryngoscope as our first choice, so and it doesn't fit in this kit dump. We're working on a new one, but yeah, next year I'll probably be able to present it, but it takes time. We have all what we need in this kit dump for standard intubation. So it kind of works as our checklist as well, because if this is full, everything is there. We also have, of course, second generation SGA, a standard laryngoscope, and of course the ultimate tool, the knife. To support what Leif told us this morning about ventilation, we are often offered this back valve mask thing because that's what the ambulance use. And we have this tendency of continuing oxygenating with that, even though we know that the proper solution is the Mapleson, giving us maybe the end tidal O2 of 85%, whereas the BVM gives us something about 74 or so, and as Leif told us, maybe even less. Just a few words on suctioning. Especially in the trauma and pre-hospital setting, it's extremely important, of course. And I have found myself doing intubation without having the suction readily available, which is why I have been a fan of checklist, even though I wasn't a short time ago. This is, as Leif showed us earlier, the Danish HEMS checklist. Is so bad in English. It may be a better acronym was so mad, because if you said Mapleson instead of the BVM, it's even more correct. Let's get back to the case. This man was, as I told you, accepted for primary PCI, and flight time to the center was 37 minutes. He has a well-functioning LMS. It says, of course, it's a LMA. Sorry about that. And he was sedated with midazolam and fentanyl. So we flew on, and then the LMAs showed to be dysfunctional. Patient starting to with hiccups and shivering. So what should you do? We were flying. And normally we do the airway management prior to lifting off. But I decided to do the intubation in flight with the video laryngoscope and 50 milligrams of rocuronium. And it was surprisingly easy and not dramatic. Here you see the Macintosh Mac video laryngoscope, and it was very uneventful. But it's not something that we do every day, which the impression of the HEMS crew member may show here. But it worked out just fine. Now he looks happy. I do as well. And the patient gives a high five or a thumbs up or whatever. So we were happy. End tidal CO2 showed to be 4.2. I learned from life that it's a good idea to insert an IABP needle, so I did. And we handed over the patient to the PCI team in the cath lab after uneventful transport. So to sum it up, what's different? We often see the patient earlier after onset of illness or injury. We have limited information about past medical history. Backup is literally not existing. Our toolbox is limited. Positioning and access to the patient may be difficult. Lighting environment may be challenging. Unseen time will give us pressure. And this whole scoop and run, stay and play, treat, load, treat, go discussion is relevant. Take-home messages. Try, I wouldn't say practice on patients because we don't do that, but do it anyway. Do advanced airway management when in the hospital, when it's nice and warm and some of the challenges are not there. Accept that sometimes the best airway management is no airway management. Use the same kit dump every time. Use a checklist tailor-made for your service. Accept to sometimes have to do advanced airway management when in flight. And practice it. It's also relevant for ground services because just doing intubation in an ambulance is different from doing it in the operating theater. And as I told, treat low, treat load, treat go instead of this old stay and play, scoop and run discussion. That was all for me. Thank you very much.
Please go back to the... Okay, thank you, Michael. Yeah, you'll see more to Michael in the workshop. That was out of the operating room. What about then if there's blood all over, we can't see anything, neither directly nor with any of the video devices. What about having some simple equipment that we can bring with us to Africa, to Greenland, to the OR when the other equipment doesn't work? I would like a method to securing the difficult airway that fulfills these criteria. It should be simple. It should be a thing that is cheap and only demands single-use equipment. It should be applicable in awake or anesthetized patients. It should be applicable in bloody airways, and it should work for oral and nasal intubation, and it should allow easy reintubation if necessary. Could I get such a device, please? Yes, you can, and you can try it in the workshop. This is what we need. Some kind of a cannula, an epidural catheter, and a tube, a small tube. This is luxury if we also got some lubricant, maybe a little local anesthetic, maybe a laryngoscope, maybe some kind of forceps, but that's not necessary. This is a wonderful technique. There are at least 20 techniques described for this, but this is the cheapest and best. It's old, it's called pulling instead of guiding. So what we do is that somehow we get a wire, it could be an epidural catheter, through the anterior neck, out the mouth, and when we got that, we make half a knot to the Murphy eye of the tube, and then we can pull the tube down into the airway. When we can't pull anymore, it's because it's stuck in trachea, in the inside of the tracheal membrane, then we start pushing, and we're in trachea. And I've got several videos with this. This This is a rock video. You can get that later on. This is a typical patient. You can see he's sitting up. He's bleeding. He was difficult beforehand. Not easy to lie him down. Not successful will it be, probably with a flexible scope. This is also a bleeding patient. He was a known difficult airway because he had a cancer. We knew him. Then he came in with rebreathing, and he came in the emergency room. This is the ENT surgeon over there with forceps and some kind of tissue, tries to stop the bleeding. He's sitting. He's fully awake. What should we do? Driving into the operating room, we'll use the cheapest technique and manage this airway. Please start the video. Then please go to the internet. Okay, good. So first I want to know he's awake. Where is the cricothyroid membrane? He's obese as well. I can't see it. I find it with ultrasonography. You'll get back to that. I put some local anesthesia on the anterior neck. I may need an access there. You see the surgeon, she's happy that we can help her. She's trying to stop it. I introduce an IV cannula through the cricothyroid membrane here that I found first with ultrasound. I aspirate, make sure that I got air, verify aspiration, and now I know I have an access to the airway. Then I introduce an epidural catheter, very cheap equipment, lubricate well, introduce it, prepare the patient, say when it tickles, spit out the tickling catheter, tell it to the surgeon, oh, when you see a catheter, please pull it out for me. Normally I don't have a surgeon in there, but if I have, I need to ask for a collaboration. So, and again, she's very motivated because otherwise she would have to manage this alone. She see, oh, there we got the epidural catheter, pull it out via the mouse, there it comes, you see, and he's awake, but he's collaborating because he knows it could be life-threatening. And now, take a thin tube, not a thick tube because they will get stuck up, make half a knot through the Murphy eye, make sure to lubricate well. And what I plan to do in a short while is to pull the distal end. You'll see, sorry, I could have cut this a bit shorter. I'll do that for next time. Now, you see, if I if I pull the distal end, I will pull the tube past the bleeding, past the pathology, and into the airway. So we lubricate well so that it won't get stuck, and then we pull until we get resistance. Because when we get to the inside of the cricothyroid membrane, of course I can't pull anymore. Then I have to change and start pushing instead. And then he'll cough, but not much because you already coughed due to the blood, so it won't make a big difference. And you don't need you see blood even there. And then verify with capnography, and you have assured the airway, and you can go on, in this case, with a tracheostomy. But now, much easier for my surgical colleague. Okay, there are many aspects of the bleeding difficult airway. Those of you who win the book can see there. Those who don't can go to the Canadian Journal and see our review paper on that. Okay, we'll go on this quest to improve success. Namely, you saw all the algorithms, all our practice. The final way out, in case we can't get any oxygen in or CO2 out, is via the anterior neck in the vast majority of cases. And interesting, look at this. This is fantastic how anatomy is created there. We've got the cricocartilage, and we've got the cricothyroid membrane that gives fairly easy access to the airway. But look at this, at least when anesthetists try this, we only got 36% success rate in this case series. The largest study ever made. Why is that? One major contributor is that patients don't have easy necks like you have. Yeah, pre-hospital many have, but in hospital and increasingly obese patients, they don't have easy necks. It's difficult to see where to go. This is one of my surgical patients. I visited her the day before surgery, and I wonder, if I need to access her airway, will it be here or here or here or here? Where will the cricoside membrane? Could it be any of these places? And I try to palpate. I can't feel anything. But luckily, now we've got means for that. We can place the ultrasound probe on the neck, and we can see the thyroid cartilage, we can see the cricoid cartilage, we can see the cricothyroid membrane and the tracheal rings. But we need some systematic approach to be able to do that in the difficult cases. Now, yes, I can. Yes, please. Yeah, you'll get to see this more, and you'll get to practice it in the hands-on airway tonight. But thank you for. Do I have a question to the, or is it self-explanatory now? Okay, good. Okay, fine. So, I want you all to learn this, the black pearls on a white string approach. So, I go through the steps briefly. So, if the patient is alive, there must be a windpipe in there. So, if you place the probe like this, somewhere there must be a trachea. There it is. You see, it's like a black horseshoe with a white lining. The white here is the tissue air border. So we only need one information, namely that this is the midpoint of the trachea in this patient. It's not necessarily in the midpoint of the patient, but it's the midpoint of the patient's trachea. Next step, we want to slide the transducer laterally so that we truncate trachea. We cut it in half here because this end of the transducer is now on the middle of the trachea. So we know that this is the midline of the trachea, and if I turn this free end of the transducer up here, I'll get a longitudinal scan of the airway, and this looks like this. The black pearls on a white string. Look, the black pearls, they're the anterior part of the tracheal rings. They're black because cartilage transmits ultrasound just like a vessel. It looks like a vein. The white line is where the tissue air border in the trachea. That's where the air starts in the trachea. Everything beyond this line is only artifact. But that's also information enough. When we have this image, we can slide the probe cranially like this until we meet this cousin. One ring that is larger, more anteriorly, and more cranially than the other one. That's the cricoid, anterior part of the cricoid cartilage. So now we're talking business. The cricoid cartilage. We can go a bit further, and then we see the thyroid cartilage coming in. And then in this step we can mark with a marking at each end of the transducer. So we got the longitudinal course of the trachea, and we can slide a needle like this under the probe, like this, and then we got the shadow from the needle here, and you'll all get to practice that. You see, so it's a cheap. The reason we use a needle, we don't want to puncture the patient. It's just we got that everywhere in the helicopter, in the ambulance, in the operating room. We can always find a needle, so we use that, and then we slide the needle under the transducer until we got this shadow right between the upper border of the cricoid cartilage and the lower border of the thyroid cartilage. And this is the level. Then we can take a pen again and mark. And now we got the exact midpoint of the cricothyroid membrane. And there are now several studies to indicate that this is very precise. This is a video in a, could you please start it, in a BMI 45 patient demonstrating the procedure. The probe placed transversely on the neck, and there you see, already now you recognize the trachea. This is the midpoint of her airway. Slide the transducer laterally and rotate it into the longitudinal plane. And there we see the black pearls and the cricoid cartilage and the thyroid cartilage. And, of course, the cricothyroid membrane here. And we can also see the depth, so we know how deep to cut or penetrate with a needle, if that's what we want. Then we can mark it with a pen. Or first we can slide the needle under it, and then you see the shadow from the needle coming in here. You see the shadow here. And when it's right between the cricoid and the thyroid cartilage, we found the place. And yeah, we can mark it with a pen here, or we could cut a hole. Is that what we need? But this is meant to be used before the patient gets blue and bradycardia. Do it beforehand, not once you have troubles. There you need a knife. But in the vast majority of cases, if we look at for instance, this NAT4 study, we knew in advance it could be dangerous. Then if there's no space, if the neck is very short like that, we don't have space for the linear transducer, then we still have hope. We can use the target technique, meaning that we first, this is a different technique. We place the probe transverse. We look for the thyroid cartilage. That's a triangular shape, and that's the only triangular shape up here. That's at this level. Then, if we move the transducer quarterly until the triangle disappears, we see this the airline. That's the cricothyroid membrane. We can go a bit further quarterly until we see the cricoid cartilage, like a C cricoid cartilage, and then we can go cranially again, and then we found it. Then we just need to mark each end of the transducer and each midpoint of the transducer. But I want you to learn the string of pearl techniques first, because that gives you the most information, and that's what you're going to practice in the workshop if you want to. This is a difficult patient, short neck, 1.8 centimeter mouth open, previous radiation therapy. Please start the video. Actually, in this case, I want to do awake intubation, but beforehand, I need to know, in case I need it later on, where is his cricothyroid membrane, and I also want it for local anesthesia, which is very efficient to put cricothyroid membrane. So I mark it as I have described, slide the needle under the transducer, and you can see the shadow from the needle on the ultrasound screen, and then mark that as well. And to prove that it's not just something we make up, I will demonstrate that there is, we'll just verify then with the target technique. So if confirm, if I'm the slightest doubt, I use the other technique to confirm. This is actually only to demonstrate. I was not in doubt at all. And then we know the exact midpoint of the cricothyroid membrane. We make a cross, and now we can use that later if we need a cricothyrotomy, or in this case, I do a needle cricothyrotomy in order to give local anesthesia for the subsequent awake intubation. Aspirate and encounter air. Verify with aspirating air. Okay, if we mark, we should of course place this mark with the patient extended neck in the position we would want it for cricothyrotomy in case we need it. Then, when we place the mark, we can sit the patient up for awake intubation or position him for instance, rapid sequence induction. Sit up. If we need it, if we need to perform a cricothyrotomy, we just put the patient back in the extended neck position, and the marking will go back as well and be in the right place. So, in this way, you can be prepared and have a probably much higher success if you need it. And if you also practice how to do it, then our success will increase. Now, I'll welcome Luz, and you can please come forward. How enthusiastic she is, both in the clinic and when teaching. And you can all get hands-on together with Luz and the other nice colleagues later on. You wanted this microphone. And I don't know if I'm allowed to say it, but she wants a handheld microphone. I'll tell you in a bar why.
Yes, that's big. Is it working? Yes. Okay. It's because of otherwise my hair would look like well, a bit odd. No. But thanks for the very funny introduction. My name is Loes. I'm an anesthesiologist in Nijmegen, in the Netherlands. My last name is Bruistens, which is very difficult to pronounce. And I'm really excited to be on this rather unique meeting today and to be able to explain some of the things that I would like to share with you about deliberate airway management and planning of deliberate airways. And especially what I would like to tell you is how you can optimize your optimal or final attempt in airway management. And I would like to do that by using 2 examples of final steps in airway management. And I would like you to keep in mind that you have to try and prevent doing things undeliberately, and you have to make sure that you get things right. So it's working, and I'm really happy that it is. Just for you to know who I am as well, I'm also organizing cricothyrotomy courses in Nijmegen, and they are called Cricourse. And that is everything I have to say in terms of disclosures. Now, how did I end up in this meeting? 9 years ago, I started an educational program in Nijmegen in cricothyrotomy skills. And We did that because we already had training facilities available, but the training facilities at the time were not leading to transfer of skills in clinical practice. So we tried to professionalize what we already had, and we have been doing that since 2013. So we developed workflows in cricothyrotomy with scalpel bougie techniques and percutaneous techniques back in 2013. And we also developed a specific training program, and by doing that we have been successful in getting good outcomes in our training programs with our residents and also in our national courses. And also it has led to a couple of successful performances in real life. So clearly we have been doing something right over the last few years, and we would like to share those results in the workshops with you. And also I would like to give you a little bit of insight of what I've learned over the years, and in a way that I think could be beneficial for any surgical or scalpel cricothyrotomy technique that you use. So as you can see, we have been working over the years with a lot of collaborators, and by working with ENT physicians, anatomists, educationalists, our 3D lab in Nijmegen, Radboud UMC, and of course our colleagues from Denmark, we've been able to get some really nice collaborations going on, new input that has led to steps forward, and some of the results will be shared today. So Ivona, or cricothyrotomy, as I mentioned before, I want to discuss a little bit my perspective on how final steps can be planned deliberately. So there are a couple of things that you can do to optimize your front of neck airway in an emergency case. And the things that you should do is make sure that you get things right. So you have to make sure that you understand the timing of the procedure and the timing that you're actually in. You have to get the procedure right, so you have to know what you're doing. And it's really important that you know what you're doing, because if you don't know what you're doing, then you don't know how you can figure out a solution for when things go wrong. And I'll be getting back to that later on. Also, you have to make sure that you get the team right. And getting the team right is more than making sure that there are enough people in the room. You have to make sure that you know what your own competencies are, and you have to make sure that you know what everyone else in the room is able to do. And that can cause fatal delays if you don't pay attention. And finally, you have to make sure that you get the post-Ivona care right as well. So about the timing. Timing is really important, and in Dutch we have a couple of words that can be used quite well to define these time frames and situations that you can find yourself in airway management. So if you have time to plan and to do whatever you want and can take days for it, then it's called elective, so electief. If you have a sense of urgency, but there's still time to call for help and wait for it, then we call it spoed, and that would be like urgent. And then if you have a case like a can't intubate, cannot oxygenate scenario, and you have no time left, then we would call it note. Now, understandably, in other countries, urgent and emergent are used a bit differently. Nevertheless, it's really important that whatever country you're from, you have to make sure that the time frames are clear to you, because the time frame that you're in also decides the type of procedure that is appropriate for the moment, but also who is going to do it. So in terms of getting the procedure right, it's really important that you know that in a true emergency scenario, we choose the technique that is quickest, which is a cricothyrotomy. And if you have a case where the patient has still a patent open airway, you can still oxygenate and ventilate the patient, but there is serious respiratory distress, for instance based on a supraglottic tumor, and possibly the patient could benefit from a tracheotomy on the local anesthesia, then obviously we call that, in my center we call that an urgent case, and that means that you can call for help, wait for it, optimize, and make sure that you do whatever you can to make sure the patient gets the best treatments. Knowing that a tracheotomy is a technique that takes more time, is technically more difficult, and we will come to that later on in the presentation as well. So it has to be deliberate at every step that you do, and time framing is really important. The most important thing when it comes to optimal performance in cricothyrotomy is making sure that you know that you can't count on the things that you don't have. So as I mentioned before, it's really, really essential that you know and you have an honest look at your own skills and knowledge sets and decide if you're both competent in performing a procedure like a cricothyrotomy, but also if you're willing to perform and stand up if you need to. As I mentioned before, we will be doing the scalpel bougie cricothyrotomy technique in the workshops later on, and there will be plenty of room to try other techniques as well. The most important things that we hope that you can get out of this session now and the workshops later on is pick up the things that could work for you in your own work environment. And some of these things are related to the anatomy. So if you want to know how anatomy can work for you and make sure that you can optimize your front of neck airway access, then we have to dive a little bit deeper in one of my favorite topics, which I like to call phone anatomy. So getting the basics right as well. So most of us call the emergency front of neck airway a cricothyrotomy, or will perform a cricothyrotomy in case of a true emergency. But we have to look at the anatomy if this medical term is actually quite right or not. So if you look at the first picture over here, you will appreciate here the area that is most of the times in booklets mentioned as the cricothyroid membrane is actually the median cricothyroid ligament. So if you were to cut only this layer, then the actual layer that you need to cut would still stand. Because underneath this layer, there are the lateral cricothyroid ligaments. So arising bilaterally from the cricothyroid cartilage, moving, fusing actually in the middle, are the lateral cricothyroid ligaments, and they fuse right in the middle underneath the median cricothyroid ligaments. So you have two ligaments on top of each other, and this one, the lateral ones, is called the elastic cone. So that's interesting because now you might appreciate better that some would call it a coniotomy. And maybe that term is a bit more precise. So if you look at this picture over here, you will see a bit more detail that can refer to the ultrasound techniques that you're going to try on later on. So here you can see the tracheal rings. The first big one is your cricoid cartilage. And you also notice that the cricoid cartilage is completely round and there is a posterior protection. So it's actually a ring, and that means that it's the only place in the larynx where the posterior wall is protected when you enter the airway. Also in this picture over here is the median cricothyroid ligament, and underneath is the lateral cricothyroid ligament, which is called the elastic cone. And it goes all the way up to form a free border to the vocal cords. Another thing that you can appreciate is if you were to enter the airway via the cricothyroid membrane and you have an angle that goes upwards, it's more easy to damage the vocal cords. So is that essential as a complication that you should spare when you have a true emergency? No, it might not be. If someone has voice problems, that's better than a person who will never have voice problems. But you have to be deliberate. So make your decisions at what you do. These two the final two pictures are here to reinforce what I've already have shown to you. So if you look at the trachea over here, then this is the elastic cone going up to the vocal cords. And what you can see is that the mucosal lining goes all the way down. And in the last picture, you will see that the lateral parts of the cricothyroid ligaments are also covered with muscle. And I will show you that a bit more in detail later on. So if you were to peel off the layers from the front of neck area and remove the skin and the subcutaneous tissue, you will get to see the platysma muscle. And the platysma muscle, as you can see over here, and sometimes you can see if I make funny faces. You can see it on my neck as well. Maybe I'll try that later on. But you can appreciate that there is no platysma covering the middle of the airway at the cricothyroid level. So that is really nice, because that means that the area where you want to cut is uncovered. Also, the layers that are underneath the platysma muscle are the strap muscles, and those are also in most patients positioned laterally from the region where you want to cut. So that is all very good to know if you are trying to think of a way to get quickest access to the trachea. So here you can see that the midline is very important. Another thing, I left out an image where you can see the major blood vessels and the nerves. I think everybody can appreciate where they are in terms of anatomy. But this also means that, as Michael just mentioned, the minority of people who are performing airway management are proficient in locating with enough accuracy the landmarks for front of neck airway. So if you know that, then you can appreciate by looking at this image that a horizontal incision made at a wrong level, or a horizontal incision made at the correct level but not in the midline, so too lateral, will not lead to successful airway access. And that is, and that is only in a normal neck. So let alone if you have a neck with changed anatomy. Now, I put these pictures in there from our anatomic lab study, and I put these in to illustrate how the human larynx looks like from the inside. So over here you see the human cadaveric larynx, and I've cut it open at the posterior wall, and then I folded it open. So you're actually looking at an incision that has been made via the cricothyroid membrane, a puncture incision, and you're looking at it from the backside. So what you can see here is, and in detail you can see it over there, is that the inside is the elastic cone, and it moves up all the way up to form the free border of the vocal cords. And here you can see the vocal cords more in detail. So the cricothyroid, the elastic cone is a ligament, and it goes all the way up to form the free border, which is called the vocal ligament, and those are the vocal cords, and we see those every day. So if you see this picture, you might better understand why, for instance, blind intubations can lead to airway trauma. Okay. So, as you saw in one of the pictures before, so this is the naked laryngeal skeleton, as I would call it. And this gives a bit of a false impression of the layers that you have to cut to get to the airway. Over here you can see the lateral part of the cricothyroid ligaments is covered with cricothyroid muscles. And over there you can see in an anatomic, in a picture that we made in the same anatomic lab study, that over here are actually muscles. And you can imagine if your incision or your puncture of the airway is not in the midline, then you have more layers to cut through, and you can make a mistake and think that you already have entered all the layers that you need and end up in a Fo's root. And you can, and that can occur with any technique, especially if you consider that you cannot make a clear cut through all the layers with a blunt subject. So how can this information lead to a even better performance in cricothyrotomy? Well, there are several things that we should mention. Can I get the video to work myself? Or? So extension is really important. It is the base of and the start of the procedure, and it is important because you will expose yourself to a better working environment. So you make sure that the area where you want to work in is placed in a more superficial position, but also in a position that is better accessible. Another interesting point is that studies have shown that the height of the cricoid membrane can increase if you extend the neck to a level where a tube 6, which most of us will use for a front of neck access, is good enough. Most of these studies have been done in trauma patients using CT scans in neutral position or ultrasound scanning in neutral position. So therefore, I think it would be wise to say that if you have a patient where the neck cannot be extended, it would be smart to use a smaller size tube and an appropriate size bougie if you want to use a bougie. So, having explained the importance of anatomy, you have to let anatomy work for you as well. So this means that where I'm from, we train people if they want to do an front of neck access via the cricothyroid membrane, they will try and get in a perpendicular way to the membrane, because that way you will be covered, if you go too deep, by the protection of the cartilage. And if you were to enter in a smaller angle, like many people do when they enter a needle technique, then there's much more chance in risking posterior wall lesion immediately from the start, with all complex complications. So in terms of getting the access point right, I've already mentioned that we know that many professionals are not capable in locating the correct midline of the airway by palpation and inspection alone. So don't count on what you don't have. If you don't have the skills, and if you're not experienced in finding the landmarks for cricothyrotomy by palpation, then make sure that you use whatever you have to get the landmarks, to find the landmarks anyway. So it is really important to try and make it yourself easy, and make sure that you at least make your horizontal incision at the right axis, meaning in the middle of the cricothyroid airway, cricothyroid membrane, and through all layers. And that is important for every technique that you do. So there are things that you can do. You can do a vertical incision if you think that there's no reason to assume that the airway is not in the midline. And a vertical incision will enable you to feel and check where the midline of your horizontal where the midline of the cricoid membrane is, and then you know where to put the horizontal incision. Obviously, you can do imaging, and then the question remains: should you be imaging all patients? Well, this meeting is about acute medicine, critical care patients. Still, you should not have to scan every patient, but you have to palpate every front of neck. And I don't think every one of us is doing that. But if you consider that many patients who needed a front of neck airway turned out to be patients where difficulty was not expected, then probably the front of neck area was not palpated, and those procedures might have been unnecessarily difficult. So try to be reasonable, but also make sure that you know when ultrasound can be of value and use it. So coming back to combine Michael's talk and my talk, you can now appreciate a bit more what you're looking at when you look at the anatomy. So if you are looking at the string of pearls and the longitudinal view, then as we have explained, you have like the small tracheal rings, and the first big one is your cricoid cartilage. And what's over here is more the median cricothyroid ligament. And what you see as the air mucosal interface is actually the elastic cone and the mucosa lying over it. So that is for the longitudinal view. For this view, it's very interesting because I've seen this going wrong in some books as well. If you look at this picture now, you can appreciate that this is the cricoid thyroid membrane. We would call it a membrane. So over here, it would be the median cricothyroid ligament. This would be the elastic cone. And over here are the cricothyroid muscles. So you can appreciate now that if you were to enter the area too laterally, that it's more difficult to mistake layers for being actually in the airway already. So we've discussed the timing has to be right, the procedure has to be right, then the team has to be right. And that means that obviously there are differences in context when cases happen in pre-hospital scenarios versus clinical scenarios. Nevertheless, you have to know in advance what the competencies are of the people that are involved with you in your case. And another important thing that I've seen gone wrong over the last couple of years is that you can't assume that there's anyone else in the room who is better at the procedure than you are. So especially for anesthesiologists, sometimes if we are in a room where also surgeons are present, or maybe other physicians are present, where you think that they are better with a scalpel, that might not be the case at all. So just be honest and make sure that you ask the right questions: who is trained, who is competent, and who is willing to start. And don't assume that anyone else is better at it, and don't let anyone go and try and do a tracheotomy that takes too long when the time frame actually said that maybe a cryotherotomy would be better. So stand up if needed. And if there's another colleague who says he's willing to start or she's willing to start, try and support that person. Now, I just wanted to point out one other thing that got me thinking because of everything we got back from our courses, is that as Michael has shown in the Airway guidelines, often if you anticipate difficulty, an awake tracheotomy is mentioned as one of the techniques that you could use. Now, interestingly, in my country, not all hospitals have a 24/7 tracheotomy service. Not sure how other countries have that, but this means that there are some hospitals where a awake tracheotomy is not a realistic option. So again, don't count on the things that you don't have. Sometimes this can be hard, and we have been trying to set up cryotherotomy trainings over the past few years because we felt it was important for people who start with airway management that they can also finish it themselves in case of true emergency. But I wonder if maybe we should be training surgeons as well in being able to perform urgent tracheotomies for certain cases. So I'm quite interested to hear your opinions on that later on in the workshops. Finally, you have to make sure that the care for everyone involved in a front of neck access case, if it happens, is well organized. And you have to do that obviously for the patients, sometimes for the relatives if the case didn't succeed. You do it for the system where you work in, but most importantly, you do it for yourself and for the team. Also, I find it very important to make sure that you know that front of neck airway is a part of your deliberate airway plan in all your patients, and as such, it's not a failure. So that is important to remember. And finally, stress before and during a procedure can actually create better focus and better performance. And stress after an emergency front of neck access is normal. But you have to be able to make sure that the rest of the team or yourself know where to get to when things are getting difficult. So I want to end with a couple of words from a case that had more impact on me than I expected. And I find it really important, so I'll be quick. So I've discussed the final step in airway management being front of neck access as a way of explaining why you have to be deliberate at what you do. And interestingly, I have recently had a case that had much more impact on me than any other case that I had experienced before, even more impact in the cases where front of neck access was needed. And I'd like to give a little bit more details of why that was. So I was called when I was on call, and I was called to go to a ward to intubate a patient. I didn't have any more information, and when I arrived in the room, there was a patient who was critically ill and had complex and severe comorbidities. Patient was suffering from a respiratory infection. It was very clear that the patient was in respiratory distress, both oxygenation and ventilation failure. And I had started with back mask ventilation. And at that moment in time, there were no restrictions in the file about airway management. So as I had been asked to intubate the patient, I asked for the medication. And also, small detail, but the patient also had an anticipated difficult airway. But we had a video laryngoscope, and we anticipated that even though there was a difficult airway, that we would be able to get either a laryngeal mask in or intubate him. So while I was asking for the medications to go and intubate the patient, the leader of the case suddenly asked me to stop. And the reason why the leader did that is because there was some hesitation whether or not the relatives wanted this patient to be intubated and ventilated. So from my perspective, from clinical view, I felt that we were in an urgent case, but there was a sliding scale of going to an emergency case, and I felt that the window of opportunity to discuss this was over. So I made that perspective clear to the team, and the leader of the case actually that went really well. She gave back to me that she had heard what I said and that she could understand that I was feeling that way, but nevertheless that they wanted to discuss with the family anyway whether or not patients should be intubated. And so they left the room to discuss with the relatives what should be done for this rather critical situation. So after a couple of minutes, I had done whatever I could think of in terms of lesser invasive airway management with adjuncts and my best bag mask valve technique. And I could not improve the oxygenation anymore, and I felt that we were sliding into an emergency case. So I made sure that everyone was back in the room and that the decision was made at that time. So at that time, they decided that they wanted to stop treatment and they did not want to intubate and ventilate their relative, and the patient died. So this case happened, and immediately afterwards, our team was called to a different case. So we unfortunately missed the hot debrief. But then when the shift was over, I sat down with my residents and with my anesthetic nurse, and I debriefed with them the case, which was really good. And then I walked to the wards and I discussed the case with the physician of the wards. And then I walked to the ICU and I discussed the case with my colleague from the ICU. And then I went home, and then the next day, it completely surprised me how much impact the case had on me. And I'm not sure if any of you can understand a bit of what I'm saying, but I guess I felt a bit overwhelmed by the fact that I had the answer to a life-threatening situation in my hands, and my hands were a bit tight at the moment, and I was asked not to do anything. And this was the first time that I had ever experienced that in a case. And even though in the end, I think we did the right thing for that patient, the reason I'm saying this is because I completely forgot to debrief myself, which is why I felt this way the next morning. And I have very fantastic colleagues who I could discuss the case with, which was really good to do. So that's lesson one. Second lesson is we've all had patients in our care where advanced care planning has not been registered when they come to critical care to our hospital or even pre-hospitally, as Mike has said. So even though we cannot make a new system by ourselves, I think it's really important for us as critical care physicians, medics, nurses, that we try and check if patients enter the hospital, especially those patients where you can anticipate that they might be intubated, patients who have a complex history, that the discussions and the conversation about advanced care planning are done in time. So in my perspective, those discussions and decisions should be made electively, possibly at the beginning of an urgent admission, but certainly not when you are in a true emergency case. So maybe we can all look out for each other there and spot and see if we can make a difference, because it's important for care for the patient, but also very important for the team. Right, so I'm trying to find the good slide to end. Not all airways need rescuing. That's my final say, and it's a bit different from how I started. You can't count on what you don't have, but make sure that you get the basics right every time. Thank you very much.
Thank you very much. Thank you. Okay. We have now been able to prepare and get a higher success rate for front leg airway. What about then offering ventilation without airway management? And what is the next step? We talked about these 7 ways of securing the airway. There's been much optimism about, for instance, high-flow nasal oxygenation, Thrive. Oh, that could be the solution to everything if we don't want to have anything in the airway, meaning tubes or metal things. We just recently did a study last year and tried only to give the high-flow nasal oxygen, and it's now confirmed the CO2 increases. There's a limited. If you go beyond 20 minutes, you will reach, in certain patients, dangerous pH levels or CO2 levels. So that's not the solution to that. What might be the solution? Look forward to the workshop. The external ventilator. Look forward to trying that. The cuirass ventilator, meaning that you have a hard shell covering your thorax. If you put negative pressure there, it will pull your diaphragm down and you'll get ventilated. Called biphasic cuirass ventilation. You should not leave without having tried it in the bar. Tried this first time a couple years ago. I was really impressed. The first time in my adult life, I didn't have to breathe. Felt so relaxing. So even the last work, I say, I want a one like this. Very brief, if you play this video, only a few seconds. Okay. So.
Works without the need for a face mask, and in a great many cases can replace or prevent a tracheostomy. Breathing consists of 2 phases, inspiration and expiration. During the inspiration phase, the diaphragm moves downwards, while the rib muscles pull the ribs out, expanding the chest, creating a negative pressure in the lungs and causing you to breathe in. When we breathe out during the expiratory phase, the muscles relax, the diaphragm moves up and in, and this pushes air out of the lungs. What makes BCV so special is that it has an active expiratory phase. BCV uses positive pressure to push air back out of the lungs. This is something that other forms of ventilation just cannot do.
Simple as that. Please play this video again. It's only a few seconds.
It causes the lungs to expand and for inhalation to occur. Using positive pressure in the cuirass, it then creates an expiratory phase.
Yeah. And it works also on cardiac output, because normally when we ventilate a patient, we get a decrease in cardiac output because we decrease the preload to the heart. But here, we improve it with suction fluid into the thorax to fill the heart. I will skip this one in the interest of time. Please play this one. So I'm now experienced, and this is my resident. We are trying to optimize how to measure CO2 so that we can do surgery without having anything in the airway. And we are very lucky at the Swiss Congress a few months ago. An abstract was presented on, this was on COVID patient, intubated and non-intubated, and it increased oxygen saturation in non-intubated patients and a reduced airway pressure and improved saturation also in intubated patients. And the good thing is that the presenter is John Diaper, who will help us at the workshop tonight. So you can all try this, and then in the coming year we'll see how we can expand the indication for this. Okay, we'll take the question at the hands-on workshop, and thank you, soon hands-on time, but before that, this will be the workshop 15 minutes past 7. We have 5 workshop stations where you can try many of the things that we mentioned today. On your little plastic card here, you see which group you are in, A, B, C, D, or E, and now comes the trick. Group A starts with workshop 1, group 2 with workshop, group B with workshop 2, and so on. And then you just go to increasing number. It's arranged up there. It's clockwise so that you can visit them all if you want. And you see you have a time slot in order not to have queuing up. And if one of the things don't interest you, that's time for buying the sandwich and the beer, and then come back to the next one. Yes. And in the meantime, now we go and make the last arrangement for the workshop. You can have participate in this quiz. So you can scan the QR code that's on your plastic card or here. Those of you who answer the most correct, or if there are more than 2 who answer all the correct answers, will have a lucky draw. and you'll win 2 books, and we'll give them out later tonight. Okay, thank you for now. See you in 15 minutes at the workshop. Thank you on behalf of the whole group.
All right, just 1 second, please.